Hello. So today I'll be talking about my thesis, which is titled Investigation on Expansion and Measurement Driven Value Agenda in Healthcare for about 8 to 10 minutes. So, when we think about healthcare, most of us imagine hospitals, doctors, medicines, long waiting rooms, but behind the scenes, healthcare is much more complicated than it looks. It is a system where many people, organizations, technologies are constantly interacting. Patients, doctors, nurses, insurance companies, government rules, digital tools, and hospital managers are all connected in ways that affect how care is delivered. Because of this, managing healthcare is not easy. Rules keep changing, new technologies appear every year, patient expectations are also rising. People today want faster service, clearer information, and better treatment experiences. All these changes make healthcare very difficult to organize smoothly. For a long time, hospitals mainly focused on providing services from their own point of view. They decided what to offer, how to offer, and at what cost. Patients had a very little say in it. But over time, researchers and policymakers began to realize that this approach was not enough. Healthcare needed to focus more on what people actually need, on what the patients actually need. This led to a shift towards what is often called as a patient centered approach. Instead of only thinking about beds, machines, and procedures, healthcare providers started thinking about how patients feel, how easy it for them to access the care, how much they should spend, and whether the treatment truly helps them in long run. International organizations, including World Health Organization, also supported this idea. They encourage countries to create systems that are fair, reliable, affordable, and focused on people's real needs. In simple words, the aim became to give better care without making it too expensive or too complicated. One important idea that emerged from this thinking is that healthcare should create value for patients. This does not mean just lowering prices. It means making sure that people receive meaningful benefits from time to time for money, the effort, and the investment that they make in treatment. To make this possible, some changes are required. Hospital needs better coordination, doctors need clearer information, payments need to be structured differently, technology must be used wisely, and patients must be treated as partners, not just receivers of services. Keeping this broader picture in mind, the research looks into three aspects or connected areas that influenced how healthcare is delivered and experienced today. The first idea focuses on telemedicine. So before COVID-19 pandemic, online medical consultations were slowly growing, but lockdowns began and people had no other choice but to rely on phone calls, video consultations, and digital prescriptions. It started as an emergency solution, soon became as a regular part of healthcare, as you can see in the graphs. Today, many patients prefer online consultations for routine checkups, follow-ups, and minor health concerns. It saves time, reduces crowding in hospitals, and makes doctors more accessible, especially for people living in remote areas. However, telemedicine is not just about convenience. It is also affects how patients feel about their treatment. Some people feel more comfortable talking from home, others miss the face-to-face interaction. Different age groups, income groups, and social backgrounds experience online healthcare differently. So understanding how telemedicine fits into people's life is important. Instead of looking at individual studies one by one, this research looked at patterns across many studies. It examines how researchers around the world have studied patient experiences with telemedicine and what themes appear again and again. By doing this, it becomes possible to see which group benefits the most, where challenges remain, and how digital healthcare may evolve in future. The second area focuses on healthcare cost. When people go to hospitals, they usually receive a bill at the end. But very few people know how that bill is actually calculated. Behind that number are a lot of factors that stay hidden, like length of stay, type of treatments, staffing time, equipment use, medicines, and more. Two important factors that strongly influence cost are how patients stay in hospital and how much treatment they receive. These two things often influence each other. A long study or longer stay can increase cost, but higher treatment needs can also increase stay. This creates a loop, and it's difficult to separate. Traditional methods of analysis sometimes struggle with this problem. When two things affect each other at the same time, it becomes hard to say which causes the other. To deal with this, the research uses a mathematical approach called a scopula rather than a direct cause and effect relationship. Instead of forcing simple explanations, this method allows patterns of dependency to be studied more flexibly. Think of it like observing two dancers moving together rather than asking who is leading. By understanding the coordination, we learn more about the system as a whole. Using this approach helps build more realistic models of healthcare spending, and it does not really heavily on the external assumptions. It works with data itself and captures hidden connections. This can support better planning, fairer decision making in the hospitals. The third area looks at patient experience in everyday hospitals, especially waiting and crowding. Almost everyone who visited a hospital has experienced long waiting lines and queues and delays. Waiting time is one of the biggest sources of frustration for patients. It affects mood, trust, and sometimes even health outcomes. Another important issue is footfall. How many patients arrive each day? Some days are quiet, other days are extremely busy. If hospitals cannot predict these patterns, staffing becomes tough. Overworked resources are stretched and patients suffer. Modern data study and tools show that hospitals having these patterns, it's very tough for them to handle these situations. By using past records, time information, and learning algorithm, it is possible to make reasonable forecasts. These tools do not replace the doctors or managers. Instead, they act like decision support systems. They help planners decide how many staff members are needed, when to have extra counters, how to organize appointments, and this research compares different statistical and machine learning techniques and see how well these can handle the predictions. It also looks at which factors matter the most, such as time, season, patient history, department type, etc. Importantly, it also uses techniques that explain how predictions are made. This makes the system more transparent and trustworthy. When hospitals understand why certain patterns occur, they can respond more wisely. When we look at all these areas together, digital healthcare, cost modeling, and patient flow, we begin to see a common theme. All of them are about improving how healthcare works for real people. They aim to reduce unnecessary stress, confusion, and waste. They try to make care more accessible, more affordable, and more reliable. They encourage systems to learn from data instead of relying only on intuition. In countries like India, where demand for healthcare is growing rapidly, these issues are especially important. Large public healthcare programs and digital health missions, like the ones that are put it in the slide, are trying to modernize services. Research like this supports those efforts by providing practical insight rather than focusing on single problem. This work look at connected healthcare problems as we see it as a system. Changes in technology affect cost, cost affect access, access affect experience, experience affect trust, and trust affects long-term health outcomes. Understanding these links is essential for building a strong healthcare system. To conclude, modern healthcare is not just about medicines and machines, it's about people, information, relationships, and choices. By learning how digital tools are used, how costs are shaped, and how patient flows behave, we move closer towards systems that are fairer, smarter, and more humane. The ultimate goal is simple: to ensure that when we seek care, they feel supported, respected, and confident, not overwhelmed, confused, or ignored. That is in the direction in which healthcare must continue to move. I would like to thank my RAC members, Professor Shaman Chaudhary, Professor G. Anand, Professor Deepak S. Kumar, for their continued support. I would also like to thank my TEC led by Professor Soumya Roy for their valuable comments and reviews. Thank you.